Case number 19. A 19-year-old male came to ER with sudden severe testicle pain for 10 to 12 hours. Color Doppler ultrasound revealed a complete absence of detectable blood flow and a heterogeneously hypoechoic enlarged right testicle, that is echopenic right testicle. Right orchiectomy was done. The testis is dark red with smooth external surface and solid consistency. Microscopic examination. These two micrographs demonstrate interstitial hemorrhage, thickened intact tunica albuginea, dilatation of the seminiferous tubules, sloughing of germ cells. These two micrographs demonstrate interstitial hemorrhage, thickened intact tunica albuginea, preserved seminiferous tubules, normal spermatogenesis, Sertoli cells, and basement membrane, interstitial Leydig cells. These two micrographs demonstrate interstitial hemorrhage, interstitial congested blood vessels, dilated seminiferous tubules, normal spermatogenesis, Sertoli cells, and basement membrane, intraluminal sloughed germ cells with retraction artifact from the basement membrane, interstitial Leydig cells, and inflammatory cells surrounded by hemorrhage. These micrographs demonstrate dilatation of the seminiferous tubules, sloughing of germ cells and Sertoli cells within the lumen of seminiferous tubules, thickened and edematous basement membrane, interstitial hemorrhage. This micrograph demonstrates sloughing of germ cells and Sertoli cells within the lumen of seminiferous tubules, thickened and edematous basement membrane. These two micrographs demonstrate interstitial hemorrhage of the testis and rete testis, dilatation of the seminiferous tubules with sloughing germ cells, dilated congested blood vessels, acute and chronic inflammatory cells. These micrographs demonstrate desquamation of the pseudostratified columnar cells within the lumen of epididymis, intraluminal many-spams, inflammatory cells, necrotic debris, and ghost cells, interstitial hemorrhage of the surrounding connective tissue. These micrographs demonstrate intact pseudostratified columnar cells, normal lining of the epididymis, intraluminal numerous sperms, inflammatory cells, and collections of sloughed Sertoli cells. Hemorrhage of the surrounding connective tissue along with hemosiderin and hemosiderin-laden macrophages. These micrographs demonstrate many dilated congested blood vessels along with numerous neutrophils, indicative of activity. This micrograph demonstrates extensive hilar hemorrhage and dilated congested vessels. Okay, what is the diagnosis? It is testicular torsion. Synonyms: acute ischemic necrotizing epididymo-orchitis, torsion ischemia, twisting of the testicle, hemorrhagic infarction of the testis. Late diagnosis. Okay, let's talk about testicular torsion. General background. Testicular torsion is a surgical emergency which requires immediate assessment and management. It should be considered once a patient presented with scrotal pain and swelling. It occurs when a testicle rotates, twisting the spermatic cord and reducing blood flow, leading to severe pain and swelling. Annual incidence is 3.8 per 100,000 in boys younger than 18 years. Testicular torsion primarily affects one testicle, with the left one being more commonly affected. 12 to 21% of neonatal cases are bilateral. Scrotal Doppler ultrasonography could demonstrate that flow in the symptomatic testis may be absent, reduced, or have abnormally high resistance. Risk factors for testicular torsion. Age. Testicular torsion most commonly occurs in adolescents and young adults, typically between the ages of 12 and 18, but it can happen at any age. Previous occurrence. Individuals who have experienced testicular torsion in one testicle are at a higher risk of experiencing it in the other testicle. Family history. A family history of testicular torsion or anatomical variations can increase the risk for future occurrences among male relatives. Cold weather. Some cases suggest a correlation between colder temperatures and an increased risk of testicular torsion, though the exact relationship remains unclear. Common causes of swelling and pain of the testicles. Physical blunt trauma, epididymo-orchitis, testicular torsion, testicular cancer, varicocele, and hydrocele. Treatment. urgent scrotal exploration, and prompt restoration of blood flow are critical. Typically, there is a 4 to 8 hour window before significant ischemic damage occurs. Reported testicular salvage rates are 90 to 100% if surgical exploration is performed within 6 hours of symptom onset. If the testis, when untwisted, shows signs of perfusion and viability, scrotal or cupexy is performed. If the testis shows no perfusion and appears grossly necrotic or non-viable, orchiectomy should be performed. Contralateral orchiopexy should be performed regardless of the viability of the affected testicle. These are the references. Thank you.